Good, let's start. My name is Tan Zhao. I'm an applied research scientist from NVIDIA. I'm honored today to introduce the speaker, Dr. Ke Yan. Dr. Ke Yan is a staff algorithm expert in the Alibaba DAMO Academy. He obtained his PhD degree from a Department of Electronic Engineering, Tsinghua University. Then he worked as a postdoctoral fellow in the Imaging Biomarkers and Computer-Aided Diagnosis Laboratory, National Institute of Health in the US. His research mainly focuses on medical image analysis, especially on disease screening and diagnosis in CT images using deep learning. He published the Deep Lesion Dataset, a large-scale and universal CT lesion dataset. He also won the RSNA Trainee Research Prize in 2018 and the Tsinghua University Excellent Doctoral Dissertation Award in 2016. He has published papers and abstracts on IEEE transactions on medical imaging, radiology, artificial intelligence, NPY digital medicine, CVPR, MICCAI, RSNA, etc., and got 4,200 citations. He also holds 6 granted patents in the US and 12 in China. Let's welcome Dr. Ke Yan.
Thank you, Sam. Let me share my screen. Okay, can you see my sharing?
Yes.
Okay, let's start. Hello, everyone. I feel very honored to present our work at the MICCAI Industrial Talk. Today, I will introduce our latest research on liver. Liver is the largest solid organ in body and is the site of many tumors and chronic diseases. We aim to use deep learning algorithms to screen, diagnose, and stage these diseases and improve healthcare. Before we start, please allow me to briefly introduce DAMO Academy. DAMO was founded in 2017 as a research arm of Alibaba Group. DAMO is dedicated to exploring the unknown through scientific and technological research and innovation. In Medical AI Lab, we focus on screening and management of common cancer, chronic, and emergency diseases in various organs using medical images, especially non-contrast CT. Our research was selected by Stanford University AI Index report and the United Nations AI for Good, Innovate for Impact, among many other honors. Today, I will especially focus on liver. First, we developed algorithms to segment the liver, choanal segments, and liver vessels. Following this, we built systems for liver tumor screening in non-contrast CT, tumor screening and diagnosis in contrast-enhanced CT. For chronic liver diseases, we have studied steatosis, fibrosis, and esophageal varices, a potentially life-threatening complication of liver cirrhosis. As medical AI researchers, we all know that organ segmentation is the foundation of computer-aided diagnosis algorithms. Our liver segmentation algorithm is developed upon well-curated labels and transformer-based networks. It is applicable in contrast-enhanced and non-contrast CT. It can handle various liver diseases, such as severe cirrhosis, ascites, and post-surgical cases. Here, we show a few challenging cases where we segment the liver and the surrounding organs, this one and this one. Liver can be partitioned into 8 choanal segments, or HC. They are useful in tumor localization, surgery planning, and can help fibrosis diagnosis. We built a model upon data from 5 cohorts. Here we show examples of HC segmentation in both non-contrast and contrast-enhanced CTs. In healthy subjects, steatosis patients, fibrosis patients, and tumor patients. Quantitative results indicate that the segmentation accuracy for healthy and steatosis patients is higher than the fibrosis and tumor patients. This is reasonable because fibrosis and tumor patients can cause liver segments to deform a lot. Liver vessel segmentation is our next goal. There are significant challenges in this task, including the diverse size complex topology, and the incomplete data annotation. To address these difficulties, we propose a new tubular structure segmentation framework named HarmonySeg. First, we design a deep-to-shallow decoder network featuring flexible convolution blocks with varying receptive fields, which enables the model to adapt to tubular structures of different scales. Second, to highlight potential anatomic regions that may contain the vessel and improve the recall of small structures, we incorporate vesselness maps as auxiliary information. Vesselness map is a traditional filter-based method that can highlight the vessel regions. These maps are aligned with image features through a shallow to deep fusion module. Finally, we introduce a topology preserving loss that leverages contextual and shape variables to balance the growth and noise suppression of tubular structures, which also allows the model to handle low quality and incomplete annotations. Quantitative experiments are conducted on 4 public datasets. The results show that our model can accurately segment both 2D and 3D tubular structures, including liver vessel, airway tree, retinal vessel, and so on. Our method outperformed the existing state-of-the-art methods. External validation on a private dataset also demonstrates good generalizability. In these examples, green indicate labels and red indicate our predictions. We can see HarmonySeg can segment small structures better than the baseline NNUNet. Our next topic is liver tumor screening in non-contrast CT. Primary liver cancer ranks the 6th in incidence rate and the 3rd in mortality rate. China is in high-risk area of hepatocellular carcinoma, or HCC. Besides HCC, there are also a number of malignant and benign liver tumors, including cholangiocarcinoma, metastasis, hemangioma, cyst, and so on. Currently, liver cancer screening relies on ultrasound and blood AFP index, which is convenient, cheap, and safe, but also suffers from low sensitivity and inter-operator variability. Enhanced CT and MR, on the other hand, is accurate but has higher risk and cost. We propose to leverage non-contrast CT to screen and classify various liver tumors. Non-contrast CT is widely used in various scenarios, such as lung nodule screening and the scans ordered for other diseases. We hope to opportunistically screen for liver tumors in every CT in the hospital and to achieve early diagnosis and treatment. However, detecting tumors in non-contrast CT is challenging because of the low contrast between tumors and normal tissues in non-contrast CT, especially for early-stage tumors. There is also interference of liver diseases such as steatosis and fibrosis, image artifacts, pseudo-lesions, atypical vessels, etc. To solve this problem, a novel framework named Pixel Lesion Patient Network, or PLAN, is proposed. It uses a mask transformer to jointly segment and classify each lesion with a foreground enhanced sampling loss. It also has an image-wise classifier to effectively aggregate global information and predict patient-level diagnosis. The main advantage of PLAN is that it can classify a lesion as a whole instead of classifying each pixel in common segmentation networks. Thus, can view each lesion holistically. Cross-attention is used to aggregate global features for each lesion. Interlesion and lesion organ relation can also be exploited by self-attention operations. In liver CT, interlesion relation is diagnostically useful, such as the metastasis and the cysts, which are often multiple. Lesion organ relation is also useful, such as HCC and ICC. HCC is often related with liver cirrhosis, while ICC may be related with dilated bile duct. plan can effectively and implicitly model these clinical priors for improved diagnosis. After experiment, we find that the patient branch is good at globally classifying whether the image contains any lesion, but it may miss small lesions. The lesion branch, on the other hand, can detect small lesions, but may produce more false positives. Therefore, we further propose feature fusion strategy to align lesion and the patient branches to improve the detection ability of small lesions. To enhance the classification accuracy of tumors, we further design a two-stage contrastive learning loss to improve healthy and tumor discrimination and benign malignant discrimination capabilities. Here are some results of our system. We cooperated with two major hospitals, the first affiliated hospital of Zhejiang University and the Shengjing Hospital. We collected more than 10,000 CTs. We also gathered 4 external centers. Doctors helped us to annotate 9 tumor types: HCC, ICC, metastasis, hemangioma, FNH, cyst, classification, others malignant, and others benign. We classify rare lesion types into two classes, namely others malignant and others benign. We also had an internal validation and external validation. The internal validation revealed good AUC and sensitivity in tumor screening. We can also classify the 9 tumor types, which an average AUC of 90%. This table shows the sensitivity of HCC screening in different stages. Overall, we can detect about 90% of the HCC cases. The sensitivity for stage 0 of HCC still needs improvement, which means a single tumor less than 2 centimeters. High sensitivity remains in external centers of about 80% to 95%. These are some examples of tumors detected by plan. And this is a large ICC. This is a very subtle HCC, together with 2 small cysts. This is another slightly hypodense HCC, and this is a large hemangioma. Importantly, we have developed our algorithm. We have deployed our algorithm in several cooperating hospitals and run it on massive real-world CT data. Our algorithm can actually discover malignant tumors that radiologists may have missed at their first read. This is an example of a metastasis missed by radiologists. You can see this is a hypodense lesion in non-contrast CT, but it is actually not very visible in contrast-enhanced CTs. So maybe that's why the radiologists missed in their first read, but our model can detect it in the non-contrast CT. And this is another example of an early HCC. We can see that there is a very subtle shadow in the liver, which is not very visible in arterial phase and the delayed phase, and our model can detect it. And this is another example of a metastasis missed by the radiologist. You can see that it is actually very small in the non-contrast CT. And this is what it looks like in the venous phase, which is also very small. This is actually a retrospective example. If we have deployed our algorithm in the hospital earlier, we could have discovered it 4 months earlier in clinical practice. This is the interface of our liver tumor screening product. The green shows the liver and the red shows the mask of the detected tumor. This list here shows the size and the probability of the malignancy of each tumor. Clinicians can view each lesion and decide whether it should be reported so as to improve their efficiency and sensitivity and to avoid missed diagnosis. Our next topic is tumor diagnosis in contrast-enhanced CT. Dynamic contrast-enhanced CT is widely utilized in imaging technology for the detection, diagnosis, staging, and treatment planning of liver tumors. Multiple images are scanned at consecutive time points. after intravenous injection of contrast agents. CECT has high spatial resolution, rapid scanning versus MRI. These multi-phase images provide valuable diagnostic information about the characteristics of lesions via the pattern of contrast agent enhancement, such as the vascularity. In this example, the hyper-enhancement in the arterial phase and the washout on the venous and the delayed phase is the major feature of an HCC. However, these characteristics may sometimes be difficult to interpret due to the high degree of diversity and the heterogeneity of liver tumors, especially for rare tumor types and the atypical imaging signs. There are also challenges including small lesion detection, malignancy classification, low accuracy in cirrhotic livers, and different scanning protocols of different hospitals. To address these challenges, a precise liver tumor diagnosis network on multi-phase contrast-enhanced CT, or LIDIA for short, is proposed for a real-world scenario. To fully utilize all available phases in contrast-enhanced CT, LIDIA first employs the iterative fusion module to aggregate variable numbers of image phases, thereby capturing the features of lesions at different phases for better tumor diagnosis. LIDIA can accept both non-contrast arteriovenous or non-contrast arteriovenous delay to adapt for different scanning protocols. To effectively mitigate the high heterogeneity problem of liver tumors, LIDIA incorporates asymmetric contrastive learning to enhance the discriminability between different classes. For common lesion types, such as HCC and cyst, we perform the intra-class attraction and the inter-class repulsion as the original contrastive learning formula. For rare lesions, such as others malignant and others benign, we simply push them away from the common classes due to the inherent heterogeneity of others class. A total of 8,000 samples from 2 internal centers and an external center was collected. We can see that most common lesion types are HCC, cyst, hemangioma, and metastasis. An average AUC of 0.927 and 0.864 were obtained in the internal and external test sets, respectively. We can see the accuracy of the others class is the lowest because there are many rare types in this class. We also conducted a reader study with 13 radiologists and found that our model is on par with radiologists with over 10 years of experience. The previous model only relies on image information, which does not conform to the actual clinical diagnostic workflow. Clinicians often combine clinical information with medical images to make accurate and comprehensive diagnosis. In this study, clinical information include both patient demographics, such as the age and sex, and 8 blood biomarkers, such as AFP and CEA, and 10 pertinent medical history, including hepatitis, cirrhosis, extrahepatic tumors, steatosis, abdominal ache, weight loss, and so on. This is a very comprehensive study about the clinical information and the tumor diagnosis. We use a large language model to extract these clinical variables from the patient's medical records. And then we use a simple logistic regression model to combine image predictions with the clinical variables to predict more accurate disease diagnosis. Interestingly, we found that the accuracy of 2 tumor types, namely HCC and metastasis, were significantly improved from 0.946 to 0.964 and from 0.916 to 0.945. The most contributing variables are hepatitis, cirrhosis, and extrahepatic tumors. And for other tumor types, the improvement is there is hardly any improvement. The proposed image model can not only be used for tumor diagnosis, but also for tumor screening in contrast-enhanced CT. We conducted two clinically relevant studies, malignant tumor screening in cirrhosis patients and metastasis screening in patients with cancers in other organs. For sensitivity, our model is significantly better than the junior radiologist, and slightly higher or on par with the senior radiologist. For specificity, our model is slightly less accurate than radiologists. These results show that our model can be applied to improve the radiologist's efficiency and the sensitivity, and to avoid missed diagnosis. We also compared the contrast-enhanced CT versus the contrast-enhanced MRI in small HCC screening, which are tumors smaller than 2.5 centimeter. Contrast-enhanced MRI are always considered the most accurate modality for HCC screening and diagnosis. We wish to compare our contrast-enhanced CT model with the contrast-enhanced MRI to see how far we have gone. We actually find that Lydia achieved sensitivity and specificity only slightly lower than the contrast-enhanced MRI, read by a senior radiologist, showing our model's clinical potential to enhance the usage of contrast-enhanced CT. And here are some examples that our model can detect. This challenging small HCC on CECT compared to MRI. Next, we move to chronic liver diseases. Compared to liver tumors, chronic liver diseases are far more common in general population. Steatotic liver disease is the most common chronic liver disease globally, affecting billions of people. Prevalence of fatty liver in China increases from 23% to 32% between 2001 and 2018. Long-term fatty liver increases the risk of cirrhosis and liver cancer, metabolic syndrome, cardiovascular diseases, and so on. Therefore, it is very important to achieve early diagnosis and management of steatosis. Existing approaches to diagnose steatosis, including ultrasound, elastography, CT, and MR-PDFF. The advantage of non-contrast CT is that compared to ultrasound, it is more quantitative and objective, and compared to MR, compared to MR and elastography, non-contrast CT is also more accessible. We propose to use multimodal data, including the patient's demographics, the non-contrast CT, biomarkers such as the liver parenchymal attenuation, serum biomarkers, and also some physical indices to input to our mouse model. By the way, our model is named multimodal AI for opportunistic steatotic liver disease screening, or mouse. We train mouse using several labels, including the liver biopsy gold standard and the radiology reports, which is silver standard. And our cohort include general population and also chronic liver diseases. Our output is the staging of the steatosis and the prognosis of progression risk of more severe liver diseases. And this is our model's framework. Mouse leverages the power of multimodal data to differentiate steatosis using a NCCT volume with cropped liver and numerical data as inputs, which allows missing features. It outputs a score named the mouse score to characterize the steatosis grade. We propose the novel learning framework consisting of an ordinal regression and designed to learn steatosis grading from liver biopsy-derived histology, or gold standard, as well as the radiological reports and as non-gold standards. Together, these components cover a wide spectrum of study population, making mouse a generalizable tool for opportunistic screening of steatosis patients in a variety of real-world scenarios. A novel image encoder was designed for extracting texture and image features from 3D liver CT. The extracted image patch tokens were processed with a transformer backbone to predict steatosis grades. We use both the imaging and the numerical features as inputs to process them with a transformer structure with interleaved multi-head self-attention blocks and our proposed missing-aware modality alignment module. Performance of mouse and the 3 compared models are shown in this figure. We compare mouse with unimodal models, including the clinical model and the image model, and also the elasticography for evaluating steatosis. Mouse has greater AUCs than the 3 compared models in both internal and external testing sets. This table further shows more metrics for our method. To interpret the learning outcomes of mouse, we employ the integrated gradients or IG method to attribute the mouse score to the input liver image. This approach enables us to visualize the alternations caused by steatosis in the liver at the voxel level. This figure shows the liver attenuation and IG values across different steatosis grades, demonstrating a clear stratification among these grades. This scatter plot illustrates the joint distribution of liver attenuation and IG, which demonstrates an exponential correlation. And this figure provides an intuitive spatial mapping of IG on 3D liver images across various steatosis grades, validated against the corresponding MRI-PDFF measurement, showing an interesting alignment, especially in several non-uniform steatosis cases. For example, the red arrows here point to a steatosis site, which can be seen on the MRI-PDFF and also in the IG of our mouse model. A reader study was conducted on internal and internal gold standard test set. We invited 11 radiologists at different levels of the profession to differentiate the steatosis grades on non-contrast CTs with and without the assistance of mouse. Our analysis reveals that the radiologist diagnosis using conventional CT biomarkers lack sensitivity, but mouse can have better sensitivity, demonstrating the potential to significantly improve the diagnostic performance. Radiologists with mouse assistance had a significantly higher AUC than the without mouse group in S1 and S2 steatosis. However, in S3 severe steatosis, mouse assistance was not so significant to improve the radiologist's performance. This is because severe steatosis can be easily diagnosed in NCCT. To evaluate the potential of mouse to transform the current standard of care of steatosis patients, we further embed mouse into the American Association for the Study of Liver Diseases, or AASLD. They have a clinical practice guidance to screen and refer patients established with steatosis who may be at risk of progression to more serious liver diseases. We, for example, steatohepatitis or advanced liver fibrosis. We also compared, we designed a workflow with mouse and compare it with the standard clinical flow that uses the transient elasticography. When comparing the AASLD standard practice with our proposed mouse pathway, we achieved higher recall and precision than the AASLD pathway, resulting in the identification of 31% more patients at risk of steatohepatitis and liver fibrosis progression, highlighting its potential to enhance steatotic liver disease detection and management. In the longitudinal prognosis task, the mouse pathway achieved a lower p-value. Next, let's move to another common chronic liver disease, which is fibrosis. Fibrosis can lead to cirrhosis, esophageal and gastric varices, and even liver cancer. China has a large population of patients with liver fibrosis, making it particularly important to incorporate liver fibrosis into disease management plans, especially for high-risk groups such as patients with diabetic fatty liver. According to a recent study, the prevalence of significant liver fibrosis, excuse me, turn on the light. According to a recent study, the prevalence of significant liver fibrosis is over 8%, advanced fibrosis is over 2%, and cirrhosis is over 0.8%. Screening and regular monitoring of fibrosis should be implemented for these populations, which will help identify and manage liver health risks at an earlier stage. Screening based on serology is convenient and low cost. However, it has lower sensitivity and specificity. FibroScan has a better accuracy, and it is also low cost and safe, but it has a limited sampling range, insufficient specificity, and especially in obese populations. MRE has the highest accuracy for diagnosing fibrosis. However, it has a long acquisition time and a high cost. Our goal is early screening of fibrosis and staging based on non-contrast CT. We designed an algorithm that employs the liver image together with the hepatic quinoid segments, as the shape of the hepatic segments is closely related with fibrosis. Our algorithm is a transformer with sparse mixture of experts. When compared with transient elastography and blood biomarkers, our model prevailed in the prediction of F2, F3, and F4 fibrosis. We also conducted a reader study to see the radiologist's performance to diagnose cirrhosis or F4 fibrosis using non-contrast CT. Our model outperformed most radiologists. Human doctors lack sensitivity in detecting cirrhosis, whereas our model demonstrates the potential to significantly improve diagnostic performance. Last, let us discuss about esophageal varices, or EV. EV is a serious complication of portal hypertension. It poses a significant clinical concern, as their rupture can result in life-threatening hemorrhage, with mortality rates of 20 to 30%. Detecting EV at an early stage is difficult, with confirmation usually requiring invasive endoscopic procedures. Given that the extent of venous dilation correlates with the hemorrhage risk, precise assessment of EV is vital. Here we show examples of 3 EV gradings, G0, G1, and G3. We also show the non-contrast CT, venous phase CT, and also the endoscopy of these images. We can see that it is very hard to detect and stage the varices in non-contrast CT. Compared to contrast enhanced CT and endoscopy, non-contrast CT offers a non-invasive, quick, and low radiation solution. Chest non-contrast CT scanning can be valuable for grading EV, although it is very hard. However, we can design algorithms to improve the accuracy. For example, liver characteristics such as fibrosis and alterations in volume can indicate the pressure within the portal venous. which is critical in appraising EV risk and severity. Portal hypertension induced changes in spleen, such as the enlargement, indirectly reflects this pressure and suggests EV bleeding risk. Therefore, we combine the analysis from the liver, spleen, and the esophagus could improve the understanding and grading of EV risks, as shown in this framework. We have developed an algorithm framework called multi-organ cohesion network on MOON that combines the liver, esophagus, and the spleen images. This idea is drawn upon radiologists' comprehensive diagnosis techniques and the physicians' clinical diagnostics knowledge. MOON employs a multi-organ framework that incorporates the organ representation interaction module, or ORI, allowing features from the liver and spleen to inform the analysis of esophageal characteristics at each step within the network. Additionally, the hierarchical feature enhancement module, or HFE, is designed to highlight the esophagus distinct morphology by synthesizing features across various levels, focusing on areas that exhibit abnormal varices. To achieve uniformity in decision-making across various organ domains, we incorporate ordinal regression loss and the canonical correlation analysis loss into our training process. We retrospectively collected a dataset of non-contrast images stratified into 4 grades of EV severity. This dataset comprises CT images of over 1,400 patients with endoscopically confirmed EV. The visualization here clearly demonstrates that EV grades correlates with liver volume, spleen volume, and the liver-spleen ratio. Validation in 239 patients and independent testing in 289 cases demonstrate superior performance of our model compared to conventional single organ models, as well as 2 human radiologists. Using GraphCam, we can pinpoint the specific areas within the model's field of focus. The OI module directly guides the MOON to accurately zone in on medically significant regions and precisely targets the distended vessels in the esophagus, the hepatic portal vein, and the spleen, which are indicative of portal hypertension and EV. And here are the publications. We have open sourced the liver tumor screening model on GitHub. And this is our team in DAMO Academy, Medical AI Lab. Thank you.
Yeah, thank you, Ke, for the wonderful talk. So we already got questions in the QA box. For audience who have questions, welcome to type the questions in the Q&A box. We got a question from Bruna. Did the time it took for doctors to analyze the exam increase with the use of this solution? How was the tool received by doctors?
Oh, that's a very good question. Actually, we are still making statistics about the time used for the doctors. I currently have no data for the time using, and we will discuss with doctors about using these products. Actually, for the screening, actually we have many products, including the screening for non-contrast CT and the diagnosis for contrast-enhanced CT. For these products, our main focus is on improving the sensitivity of doctors and reduce the missed diagnosis of liver tumors. So it may increase a little for the doctor's time, but I think the cost is valuable.
Yeah, thank you. I have a question. So recently, DeepSeek has received a lot of attentions, and especially its reasoning function. I was wondering whether you have plans to incorporate those reasoning uh, functionality to your diagnosis tool, because it seems to me that it would be easier for doctors to accept such a diagnosis result if there's some reasoning show up for the
Yeah,
result.
yeah, yeah, yeah. This question is also very good. Um, Actually, we have thought about that idea. Um, so I read a few papers which discussed this idea, and they use a large language model to do reasoning and for a better diagnosis. So I think the bottleneck within this idea is how to describe this image for DeepSeek or other large language models. So you first need to develop an image model that can actually accurately describe the lesions and the appearance of the liver and so on, and provide it to the language model, and then you can make a let the model to make more reasoning for better diagnosis. But however, the describe of the lesions and the livers is not a trivial task. This is a very subjective task and lacks training data. So I think we need more efforts in this direction.
Thank you. We got more questions from the audience.
Mhm.
There's a question from Hao. How do you manage ground truth vessel quality? Some of them are thick and some may be thin, um, which means different criteria upon doctor labeling.
Yeah, the liver vessel is a very challenging task. So we used several public data sets. There are three public liver vessel data sets, but their label quality is not very good. So we used a few strategies to make the model adapt to the incomplete label, and then we train on these incomplete labels, and then we use our model to infer the original data and get better liver vessel masks, and then we retrain our model, and this is how we improve the label quality. Actually, labeling the vessels in the liver it is very challenging. Yeah.
Thank you. Next question from Sohail. Can you elaborate a little about your individuals in segmenting and using the arteries and veins of the liver, as you referred to at the beginning of your talk, about architecture and performance of your AI model?
So the question about how do I use the results of liver vessel and segmentation, is that correct? I did not fully get the idea.
I suppose so.
Okay. Uh, segmenting using the arteries. Let me see. It's how about segmenting and using the arteries and veins of the liver. For the correct ones. So I think maybe about the architecture of the liver vessel segmentation. Uh, Actually, the architecture is a little bit complex, which is shown in this picture. So I'm not very uh, uh, I'm not very sure if I can explain it clearly in this talk. But our paper have been submitted. If you got accepted, you can check it and for better understanding. So basically, we improved on the network architecture, on the Bessel's map input, and also on the loss to accommodate for missing annotations. And after that, we use this liver vessel segmentation in our liver tumor screening and diagnosis model, because we find that sometimes the liver vessel in the non-contrast CT can be uh, can be confused with the tumor. So if we incorporate the liver vessels mask into training this tumor model, the tumor screening accuracy can be improved. That's one application of this liver vessel masks. And another application is to use the liver vessel masks for surgery planning, and this is not what we have done yet.
Thank you. The next question. This is a great talk, thanks. I have a question on liver screening with CT. What do you think about the radiation dose introduced by CT for screening purpose? What would you recommend to create a clinical screening protocol with CT imaging?
Yeah, I think for liver tumor screening, there are different protocols in different area. For example, in China, there may be a lot of non-contrast CT. It is very widely used. But in other places such as the US, maybe contrast CT is more commonly used in liver. So our primary purpose is to use non-contrast CT. This non-contrast CT and even low-dose CT, we find that the low-dose CT, the dose decrease in dose does decrease the accuracy, mainly decrease the sensitivity of some small tumors. So there is a balance between dose and accuracy. But for contrast enhanced CT, I think the tumors may be more visible, so you can decrease the dose and expect for better accuracy than non-contrast CT. So this is a very interesting research topic. I think our model can be combined with low dose non-contrast CT and low dose contrast enhanced CT and achieve comparable sensitivity compared to normal dose CT. And this is a very interesting and promising research direction.
Thank you. The next question. Do liver HCC segmentations help for therapy planning or surgery planning? Doctors need to make the margin bigger for therapy purpose. My second question is about MR elastography. Does it have an additive value for diagnosis when used with deep learning or current anatomical modalities are enough?
For the surgery planning, I think yeah, actually, contrast enhanced CT is often used for surgery planning of liver tumors. So you need to segment the liver. You need to develop algorithms to segment the tumor, the liver segments, and also the big vessels to plan for the surgery. So this is yes, this is a very good application for the model. And for MR elastography, I'm sorry that I'm not an expert on this direction, so I cannot answer your question.
Thank you. Next question from Xu. Integrating imaging data of the liver, spleen, and esophagus is a brilliant approach, as signs of cirrhosis are distinctly reflected in these organs. Would you consider exploring multi-model strategies in future studies? For example, predicting liver function in cirrhosis patients for assessing the risk of postoperative liver failure in HCC cases?
Yeah, I think that's a good idea. Incorporating multiple organs and multimodality data to evaluate the patient's risk in liver disease. I think that's a good idea. You can actually our research have considered that approach in our liver steatosis model. We combined the image feature and also other indices such as biomarkers, serum, and physical indices. Actually, I found an interesting phenomena. Let me see. So in this task, we wish to combine the image model with the biomarkers, including the demographies, blood biomarkers, and medical history. I tried several ideas, I try to combine these clinical variables into the network of the image model. However, all of these attempts failed to improve the accuracy. But at last, I try to incorporate directly combine the prediction of the image model with the clinical variables via a simple machine learning model, and got improved accuracy for two diseases. And this makes me think that sometimes if you want to use multimodal data, maybe you want to make your model simpler instead of more complex, and you can expect some improvement in accuracy, and also the model will be interpretable. And also, sometimes you may not expect that all the accuracy of all your expected outcome to improve. For example, we have 9 tumor types, but only 2 tumor types have improved, because these 2 tumor types is closely related to our medical history used in this model. That's why it can improve. And for other tumor types, actually the image model can already make a very good prediction. And this is what we have learned from this experiment.
Thank you. Next question from Wenting. What is the smallest lesion your algorithm can segment, like those metastases, which are very small and hard to detect?
Yeah, we have set an size threshold of 3 millimeters in our model. For lesions smaller than that, we directly remove them because they are more likely to be noises.
Thank you. Next question from Gary. Thanks for the great presentation, Ke. I noticed that there are a lot of non-imaging features being combined with images in your methods. Can you please elaborate on the most effective method you found for embedding non-image features with image features?
Yeah, I just answered that question for this steatosis model. No, for this yeah. The most effective model I find is simple machine learning models. Yeah.
Thank you. Next question from Malik. Thank you for the presentation. I have a question about the quality of the training data, given that CT is less expensive than MRI in terms of details. Sorry, that CT is less expressive than MRI in terms of details. Does the use of MRI only improve the results in your opinion?
Yeah, I think for liver, especially for liver tumors, MRI are always considered as the most accurate modality, especially for contrast enhanced MRI and for some HCC related contrast agents. So the reason that we use CT is because it is more widely accessible, and it has a rapid scanning time, and also have higher resolution. And I think the device, if we combine CT and MRI, it will have a better accuracy. And if we simply compare contrast enhanced CT with contrast enhanced MRI, MRI still has a slightly better accuracy than our CT model.
Thank you. We are about time. Thank you, Ke, for the wonderful talk, and thank you everyone for joining this talk. If we got permission from speakers, we will upload the recorded video to our YouTube channel. And thank you so much.
Thank you, Sun. Thank you, everyone.
Thank you.
Bye.
Bye.